Okay, so good evening, everyone. Today, I am doing it slightly different from what I had done it previous times. So I am going to cover the use of ultrasound for diagnosis of hip dysplasia and also the early treatment of hip dysplasia. So it's going to be a slightly longish lecture, and I have divided it into three parts. The part A would be basics of ultrasound anatomy. Part B would be the conservative treatment of DDH, and part C is the screening guidelines that we follow for diagnosis of hip dysplasia. So starting with the first part, uh, our aims of understanding the ultrasound anatomy are to understand how an ultrasound scan is done, how to read an ultrasound, how to perform these measurements correctly, and then how to classify a hip correctly based on the graph classification. I will be starting with a small introduction. Developmental hip dysplasia is the commonest disorder of the locomotor system, and it causes 10 to 15% of total hip replacements below the age of 50 years. Also, 54% of the hip dislocations do not have any clinical signs or risk factors, which stresses the importance of having a robust screening program. So the reason we use ultrasound is because the head of the femur and most of the hip joint is cartilaginous in a neonate and infant, and hence we can't see them on X-rays. And in theory, there is a risk of radiation exposure with every X-ray that you do. So since we have an ultrasound which gives a lot more detail about the anatomy of the hip joint, an ultrasound is preferred to doing X-rays in a infant or a neonate. So the equipment that is used is a linear array transducer with a frequency of 5 to 7.5 megahertz. The frequency may differ depending on the make and the company that you're using, but a higher frequency gives you a better resolution. However, the penetration reduces with a higher frequency. That is why in a small neonate or maybe in a preterm child, you would use a 7.5 megahertz frequency so that you will get the best resolution possible. But if your child is slightly older, closer to the age of 3 months, then you would want to go down on your frequency to 5 megahertz to give good penetration from your ultrasound beams. So, Professor Graf has described the use of this cradle and probe guide that he uses for each and every patient who undergoes an ultrasound scan by the Graf method. We unfortunately don't have access to this, but I mean, being on the Graf course recently, I've realized that using this cradle and probe guide actually makes your uh, work quite easy, and you're able to scan the hip within a few seconds. So there is a very particular technique that he describes of doing the ultrasound scans, wherein the child is placed in the lateral position, and you use the two fingers of your hand to palpate the trochanter. You put the jelly of the ultrasound between the two fingers, not on the probe as we routinely do, and then the probe is brought down from the top between your two fingers, pushing the two fingers apart, as you can see here. And then you start moving the probe from front to back to see the entire anatomy of the hip joint. And then you're supposed to stop when you see the lower limb. And then, depending on the plane you are in, whether you're anterior or posterior, you would rotate the probe to get the standard plane. I will start off by describing some basic terminology of the sonoanatomy of the hip joint. So, an echo hole is an anechoic or a hypoechoic area which is caused by tissues of low echogenicity, such as the femoral head and the greater trochanter, that is the proximal femur. So these tissues, they appear black or slightly, anechoic, as they call it on the ultrasound, but they would allow the rays of the ultrasound to pass through them. In comparison, an acoustic shadow is an anechoic area which is caused by total reflection of ultrasound beams after they hit that area. So this is the ilium, and this is the chondro-osseous border of the proximal femur. So as you can see, when an ultrasound ray hits the ilium or the chondro-osseous border or any other ossified structure for that matter, the ultrasound beams get reflected back, and you cannot see anything beyond the ilium, beyond that ossified structure. So this area is called an acoustic shadow. So for the rest of our talk, I will be, because we are used to seeing an X-ray of the hip joint in such a position wherein the ilium and the pelvis is cranial and the hip, the femoral head is caudal. We are going to flip this image now so that for the rest of the presentation, our ilium will be on the left side of the screen. So the cranial portion of the hip joint will be on the left side of the screen. The caudal portion will be on the right side of the screen. The medial portion will be on the inferior part, and the lateral portion will be at the top of the screen. So this is how the orientation will be. Ilium on the left side, femoral head on the right side. The greater trochanter or the superficial structures will be, or the lateral side will be on the top of the screen, and the deeper structures will be on the lower part of the screen. So then we'll talk about the ultrasound characteristics of each of the various tissues that we usually try to visualize on an ultrasound scan. So the bone produces a bright echo, as I just previously said. So this is the chondrosseous border. This is the ilium. So these bones which are ossified, an ossified bone will produce a bright echo, and there will be an acoustic shadow which will be beneath that ossified structure, which will reflect all the waves back. On the contrary, all collagenous connective tissue and all fibrocartilaginous structure, they will produce a highly echogenic but echolucent image. So what do I mean by that? Highly echogenic means that it will appear white on your ultrasound image, and echolucent meaning even though they are bright, as opposed to bone which reflects all the rays, you can still see tissues which are beneath those echogenic structures. So our collagenous structures and fibrocartilaginous structures which we routinely see around the hip joint is the capsule which covers the femoral head. Then we see the labrum, which is this small triangular structure here, which is also made up of fibrocartilage. And on the image on the left, this bright spot that you can see is actually a small portion of the ligamentum teres, which can also be seen at times. So all these ligaments, they would appear as bright and echogenic. Then the hyaline cartilage, which is the head of the femur and the cartilaginous part of the acetabular roof. These two structures appear either hypoechoic or anechoic. So here on these two ultrasound films, there are two anechoic structures or hypoechoic structures which are adjacent to each other, and that is why you can't make out that there are two structures. You might imagine that these are there is just a single structure here, but this egg-shaped structure here is the femoral head, and just touching the femoral head, this small polygonal area, this is the cartilaginous acetabular roof. And because these two structures are of the same echogenicity, you can't make out any distinction or any border between the two. But these are two distinct structures. This is not just a single structure here. So then we will talk about the anatomical, the morphology of the hip joint that we see in an ultrasound scan. So this is what a proximal femur in a neonate looks like. So this is the head and the greater trochanter, which is completely made up of cartilage. And this is the metaphysis of the femur, which is made up of ossified bone. So the junction between the chondral and the osseous elements of the femur is called the chondro-osseous border, and which appears like a curved structure on your ultrasound scan. So this is the chondro-osseous border. If you can see the similarity between this. So this is the head of the femur, this is the ossification of the greater trochanter, and this is the chondro-osseous border, meaning the junction between the cartilage and the bony aspect of the femur. So there are three appearances of the chondro-osseous border on an ultrasound scan. Firstly, it could be like a very continuous line going all the way from the bottom all the way to the medial aspect of the head of the femur, which is usually seen in younger patients like neonates. Then it could appear as palisades. The lower portion of the chondro-osseous border is continuous, but closer to the head of the femur, you can see some discontinuity in the chondro-osseous border. This is seen in slightly older kids. And as the child's age advances, you can only see the lower part of the chondro-osseous border. And because this chondro-osseous border is ossified, the medial part of the chondro-osseous border kind of gets hidden underneath the acoustic shadow. Then we are coming to the femoral head. This femoral head is the egg-shaped structure, which is anechoic or hypoechoic on an ultrasound scan. And if you can appreciate, there are certain small white spots within the femoral head. So these white spots are the vascular sinusoids which give blood supply to the cartilaginous femoral head and the greater trochanter. Then, as the child grows in age, these vascular sinusoids coalesce and they eventually give rise to the development of the ossific nucleus of the femoral head, which is visible on an ultrasound scan at least 4 to 6 weeks before you can see it on an X-ray. Now, there are some issues with the ossific nucleus. To use the ossific nucleus for diagnosis of hip dysplasia, firstly is that the assessment of the size. What happens is because once the ossific nucleus starts ossifying, the ultrasound rays, they just hit the nucleus and then they turn back. So you can't really see the entire nucleus, which might be a circumferential or a round shaped structure here, but only you can appreciate the lateral edge of the nucleus. So you cannot really use an ultrasound to assess the size of the nucleus as opposed to what we can use the X-rays. So like I said before, the ultrasound rays touch the ossific nucleus and then they go back. So this leads to what is called a half moon phenomenon on ultrasound. And basically, again, it is reiterating the fact that you can't use the ultrasound to determine whether the size of the ossific nucleus. And again, the position of the ossific nucleus can be highly variable on an ultrasound. So it may not always be in the standard plane of your ultrasound. So it may be slightly eccentrically, the ossific nucleus may be slightly eccentrically placed. So you cannot determine the hip dysplasia based on the location of the ossific nucleus. For example, when we do an X-ray and we compare the location of the ossific nucleus in respect to the Hilgren-Reiners and Perkins lines, here you can't use the ossific nucleus to determine whether the hip joint is centered or decentered. And eventually, as the ossific nucleus increases in size, it becomes so big that it obscures everything which is medial to the ossific nucleus. And then at that point in time, you can no longer use the ultrasound to diagnose hip dysplasia. Then the next structure that we are going to talk about is the synovial fold and the hip capsule. So the hip capsule, it encloses the head of the femur. It is in close contact with the head of the femur, and it eventually merges with the perichondrium of the greater trochanter distally, and it merges proximally with the superior edge of the acetabulum here. So distally, where the capsule of the hip joint, where it merges with the greater trochanter, there is a small reflection of the capsule onto the greater trochanter. This reflection is called as the synovial fold. So the synovial fold on an ultrasound can appear as a small radiolucent spot, or sometimes it can appear as two parallel lines. Then comes the labrum. So the labrum is an echogenic structure which is in close contact with the femoral head. And there are 4 ways in which you can identify the labrum. So firstly, it is echogenic. Then it always lies distal and lateral to the hyaline cartilage. So this is our cartilaginous roof, and the labrum is distal and lateral to the. So again, just remember that the image is flipped. So this is actually lateral, and this side is distal. So the labrum is distal and lateral to the echogenic cartilaginous roof. The other thing is that the labrum will always be in contact with the femoral head. Whether the hip is centered or decentered, the labrum will always be in contact with the femoral head. Then the third way to identify the labrum is if you trace the capsule of the hip joint, starting from the trochanter and then proceeding proximally, you can see the point at which the capsule starts to diverge away from the head of the femur. That is the position where your labrum will be located. And the fourth definition by which you identify the labrum is that it will be caudal to the perichondrial gap. So the meaning of that is that the area where the capsule attaches to the lateral aspect of the acetabulum, there is a bright echo there, and the capsule appears bright distally. And in between the two, there is a small radiolucent area, which is called a perichondrial gap, as you can see here. So there is distally there is capsule which is bright. Proximally there is capsule also which is bright. And in between this black area, this is the perichondrial gap, and caudal to the perichondrial gap, this triangular structure, this is the labrum. and this anechoic area here, that is the perichondral gap. Then coming to the cartilaginous roof, which is always immediately medial and cranial to the labrum. So this black structure, which is in touch with the femoral head and just medial to the labrum, will be your cartilaginous roof. And the last thing is the ilium, which is your bone, and then the lower limb of the ilium. So you should be able to trace the ilium starting from the top and then going down all the way up to the lower end of the ilium. Then what is described is the turning point, which is the most lateral aspect of your concave bony socket. So you're supposed to identify the turning point. You're supposed to trace the outline of your acetabulum starting from medially and then going laterally. So the point at where the concavity turns to the convexity, that is going to be your turning point. So you're looking from inside to the outside, and there is usually a small acoustic shadow just medial to the turning point, and your turning point would be the lateral edge of that shadow. I'll just show you one image before I proceed so that there is no confusion. Sorry. You can see an acoustic shadow here. I hope everybody can appreciate that. You can see some bone there, and then there is a black spot, and then again you can see bone. So concavity turning to convexity, and then there is this acoustic shadow. So your turning point would be just at the lateral end of this region. So the three pillars of using the graph method of hypsonography is your examination technique, which I initially started off by saying the use of the cradle and probe guide, and then how to specifically identify the greater trochanter and put your probe between your fingers, and then the forward to backward scanning technique. Then there is an anatomical identification checklist, which is the checklist 1, and the usability checklist, which is checklist 2. So I think the examination technique I just spoke about. The anatomical identification checklist includes all the 7 structures that I just spoke about. The first structure is the chondro-osseous border. The second structure is your femoral head. The third structure is the synovial fold. Fourth is your capsule, which goes from the synovial fold all the way up to the top. Then the fifth structure is your labrum. Sixth structure is the cartilaginous roof. And the seventh is the bony roof, which is your ilium, so you're supposed to, again, trace the ilium all the way from the top, going down up to the medial end. So this is your anatomical identification checklist. And unless and until you can see all these 7 on an ultrasound image, you're not supposed to use it for diagnosis and further treatment. So even if a single structure is missing, you should not use an ultrasound scan for the diagnosis. Then comes the second checklist, which is the usability checklist. So in this, you should be able to see the lower limb of the ilium, which would be structure 1. Then your cross section should be through the mid portion of the bony roof, which is identified by the fact that your ilium appears horizontal and as a straight line. And you should be able to see the labrum of the acetabulum. So all these 3 structures should be categorically visible to clear the usability checklist. So only when you have passed checklist 1 will you go to checklist 2, and only when you have cleared the checklist 2 will you be able to classify the patient as per a graph classification. So this is how a cross section through the mid portion of the bony roof will look like, wherein the ilium will appear as a straight line. If you are slightly anterior to the cross section, then you can see that the ilium turns towards the probe. So this is the ultrasound probe here. When the ilium starts going towards the probe, then it means that your cross section is too anterior. And if you're too posterior, then you will start seeing a small trough here of the gluteal fossa. So that indicates that your section is too posterior. So your section should neither be too anterior nor too posterior. It should be through the center, which would give you a very nice and straight ilium. So then we will talk about how to measure the alpha and beta angles. So you are supposed to draw 2 lines The first line is your baseline, which starts from where the perichondrium of the capsule, where it meets the ileum. So you draw a tangent from that point along the lower limb of the ileum. Then to measure the alpha angle, you draw the bony roof line, which starts from the lower and the innermost end of the bony roof. And it is supposed to be rotated so that it just touches the roof here. So the angle between the bony baseline and the bony roof line, this is your alpha angle, and it should normally be more than 60 degrees. Then your beta angle, it is measured between the center of the labrum to the point on the bony rim. So if you draw a line connecting the bony rim with the center of the labrum, the angle which is formed between this line and the baseline, this gives you your beta angle, which should normally be less than 55 degrees. Although there is a lot of variation in the in the amount of the beta angle. And if you draw all the three lines together, you would notice that your three lines seldom meet at one point. So if the radiologist is giving you a report wherein you are seeing all the three lines drawn from a single point starting here, then they probably are not correctly measuring the alpha and beta angles. So here on this example, this is your baseline. This is your acetabular bony roof line. And your cartilaginous roof line, this goes between the turning point and the center of the labrum. So as you can see, these even on an ultrasound scan, they hardly meet at the single point. So this is the calculation of angles. Then I will talk a little bit about a qualitative description of the bony roof. So the bony roof can be classified either as good, deficient, or poor if you're assessing it qualitatively. So if you could imagine that this was a cliff, and if some person wanted to jump from the edge of the cliff, this cliff being very steep, the person would actually hit the cliff somewhere at the bottom. And that is how a good bony roof will look like. It will be very deep and steep. As opposed to a deficient bony roof, where you can see that the cliff is slightly sloped. So if some person is standing on the edge of the cliff and wants to jump down, he will hit the sides of the cliff, not the very bottom. And that is how a deficient bony roof will look like. And a poor bony roof will, there will be no cliff, there will be just a small shallow slope. Then, okay, so coming to clinical examples. So this is a good bony roof, wherein you can see a very nice and sharp cliff here and a steep acetabulum, as opposed to a poor bony roof, wherein you can't see anything resembling an acetabular cup. All you can see is a very flat ilium. Sorry, yeah. And this is the deficient roof, wherein you can see that the cliff is slightly shallower, and it is between this and this. So it is slightly shallow. Then the bony rim also is qualitatively described into four qualitative descriptions. It can either be sharp, wherein it is very nice and sharp here. The blunt bony rim means that you will be missing a small corner here at the edge of your bony rim. A rounded bony rim is where there is, it is neither blunt nor sharp. It is, you can trace it to be a smooth round, and flat is where, again, you can't actually make out the bony rim. So these are ultrasound examples. Here you can see a very nice and sharp bony rim here, as opposed to a blunt. If you can imagine, there is a small corner piece missing here from a chip of the corner missing. So this is a blunt bony rim. This is a rounded bony rim where it is not really angular nor blunt. So you can probably resemble something like an arc. And here it is flat again. Similarly, the cartilaginous roof is described as either being covering or displaced. Okay, so so long as the turning point is above your labrum, so the line which you draw, the line of the beta angle, can I annotate? Okay, so I'll just use. Just gonna annotate. Just a second. Oops. Okay. Okay, so this was my turning point here. And this is the labrum. So if I draw a line between the turning point and the labrum, so if the turning point is above the labrum, or vice versa, if the labrum is below the turning point, then the cartilaginous roof is covering the head. Okay. So here in this case, this is the labrum, this triangular structure is the labrum, and your turning point would be concavity to convexity, somewhere here. So if here, if you can imagine this line, this is almost like a vertical line. So on this one, the labrum is the cartilaginous roof is displaced proximally. Okay. I hope you can understand this. And in the most severe cases, the graph 4 hips, sometimes here you can't really make out where the labrum is, but then what happens is eventually as the hip dislocates higher and higher, the cartilaginous roof gets pushed distally and downwards. So that is how you differentiate between a graph 3 and a graph 4. So here you would classify the hips based on whether they are centered or decentered. So graph type 1 and graph type 2 are centered hips, whereas graph type 3 and graph type 4 are decentered hips. So in any centered hip, your bony roof is going to be good. Sometimes it may be deficient for age of the child, but the joint could still be centered. In your decentered joint, the bony roof is going to be poor. Your bony rim is going to be flat. And the cartilage roof will be displaced upward in a graph 3 hip as opposed to a graph 4 where the cartilage roof will be displaced downwards. And in type 1 and type 2, your cartilage roof will be covering the femoral head. So then graph has given this very extensive classification of the types of hip dysplasia, wherein the type 1 is when the alpha angle is more than 60. Type 2 is when the alpha angle is between 43 and 59. So type 2 again is subclassified into two types. Type 2A or 2B is where the alpha angle is between 50 and 59. So the difference between A and B is only the age of the child. Any child who is less than 3 months would be classified as a graph 2A, whereas any child who is more than 3 months with an alpha angle of 50 to 59 would be called a graph 2B. A type 2C is when the alpha angle is between 43 and 49. So that is the C actually stands for critical, which means that the hip is at risk for dislocating. And it is really important to diagnose these patients and treat them early so that we prevent a dislocation and make the hip as normal as possible. So the beta angle actually has a lot of variation, as I had previously said. So the real importance of using the beta angle is primarily for this class of type 2C hips. So in a patient who has an alpha angle between 43 and 49, but if you measure the beta angle and you get it more than 77, then graph has classified them as a type D hip or a decentering hip. So a type D hip is not a 2D hip. It is only classified as graph D, which means that the hip is decentering. Now, what graph says is if you identify a type 2C hip, you are supposed to perform a dynamic scan by giving a slight axial push to the hip to see if your beta angle worsens with like a Barlow maneuver. Okay. Sorry, an Ortolani maneuver. You perform an Ortolani maneuver, and if your beta angle is worsening beyond 77 with your Ortolani maneuver, then it indicates that your hip is it is at risk of dislocation, it is unstable, and then you should treat those hips. And in graph 3 and graph 4, you can't really measure the alpha angles because the hip is so bad that you're not in the standard plane, and B, the acetabular socket is so shallow that you can't really make any meaningful measurements. Then just for sake of completion, I have added a few other methods which have been described, which still are used in certain parts of the world, although they are not as popular as the graph method. So Turgeson has described his way of scanning, wherein he has described this bony rim percentage, or what we also call as the femoral head coverage, which is the percentage of the diameter of the femoral head that is covered by the bony roof divided by the total diameter of the femoral head. So he calculated the mean bony rim percentage to be 55% for girls and 57% for boys. And he classified all hips as unstable if the bony rim percentage was below 50%. Then the second measurement that Turgeson had described was the lateral head distance, which was the distance between the lateral tangent to the ossific nucleus and the lateral bony rim. So he has described a set of values for differing ages. Although, as I have described in the graph method, you can't really rely on the ossific nucleus to make a diagnosis of hip dysplasia. So this measurement has actually fallen out of favor. Then there is a dynamic method of ultrasound by Harkey, in which he describes using a coronal view and a transverse view. And again, both of these are done in flexion and in extension. So you would have a coronal flexion view, a coronal neutral view, a transverse flexion view, and a transverse neutral view. So, and again, these are done static and dynamic. So when doing a dynamic scan, you would be giving an axial push on the hip to identify if the hip becomes unstable with axial loading. So in the coronal view is very similar to what we have just been speaking about. In the transverse view, you can see the femoral head and the ischium here. The labrum will be seen posterolaterally, and this is the shaft of the femur and the chondrossus border here. So he has described 4 quadrants wherein you draw a line along the superior edge of the ischium and draw a second line perpendicular to it. And if your femur is anteromedial, then it is normal. But if it is anterolateral, then it is subluxed. As per Harkey, the hip is classified as normal, subluxed, slightly dislocated, and dislocated. Although I couldn't really find out the exact description of how do you differentiate between a slightly dislocated versus a dislocated. Then there is a Suzuki method of simultaneous examination of both hips using a large linear probe and an anterior approach. So this produces an image which is very similar to a CT scan or axial CT scan that we perform after our close reduction of hip dislocations. So these bright structures here are the 2 pubic bones, which you can see similarly on the CT scan. And the femoral head, which we should be seeing, is this black anechoic spot. So Suzuki has described drawing 2 lines, the P line which goes along the anterior edge of the pubic bone, and the E line which goes perpendicular to the P line from the lateral edge of the pubic bones. And if your femoral head is below and below the P line, lateral to the E line, then it indicates that the hip is centered. So why has the graph method become so popular is because that it is very clear and precise. It is a quantitative method, so you're actually measuring an alpha and beta angle, and you're going to comprehensively classify the hip based on your measurements and your classification. And because you're using a standardized technique, it has better reliability and it is less observer dependent as opposed to the other methods which I have just spoken about. So just to summarize, we have to go through the anatomical checklist first, then the usability checklist second, and ensure that your sonograms are in the standard plane before we make a diagnosis. We have to measure alpha beta angles correctly. We have to describe the bony roof, bony rim, and cartilaginous roof. So your the qualitative definition, the qualitative description of your bony roof, bony rim, and cartilaginous roof should give you a rough idea of what graph type you're looking at. And if there is if there is a stark discrepancy between what you think it is versus what you're measuring on the alpha and beta angles, then you have to revisit and see what is going wrong. After you have measured everything correctly, you will classify as per graph and then you will decide about treatment. So before we proceed with treatment, are there any questions?
Bhushan sir,
Yeah.
could you please explain that, when the alpha angle comes in the 2C group, how do we correlate it with the beta angle? Could you just explain that again?
Okay, yeah. So a 2C is when the alpha angle is between 43 and 49. Okay. So to differentiate between a 2C and a type D hip, the beta angle is going to be of help. Okay. So if you have measured an alpha angle which is between 43 and 49, but your beta angle is more than 77, then it is not a 2C hip, it is a type D hip. Is that clear?
Yes, sir. And the management varies for the type D hip, right? That you'll be speaking about in the later slides.
So the management, again, it would not vary for a 2C or a 2D. Sorry, for a 2C or a D hip, you would want to treat them. But
Okay.
again, now we are doing this RCT wherein we are trying to study the outcomes of 2C by, we are randomizing them into two groups. So 2C also is a part of our RCT. But classically, if you look at the graphs treatment protocol, he would treat all 2C hips.
Okay.
Any other questions?
Bhushan sir,
Yeah.
could you just go through the method of tracing the bony roof and cartilaginous roof line again?
Okay. I might just.
And so with that, could you show us some examples of how to exactly get to the turning point? Because some of the scans, when you said this is the turning point, I thought that something else was the turning point. So along with that roof thing, maybe if you could show
Yeah,
us.
actually, I was just going through this presentation. I don't have a lot of images which are in the perfect standard plane, because initially what we were doing is what I had trained in by doing a coronal flexion view, and that is what was required for our meadow study. But off late, I've started doing all our scans in the standard.
Standard.
So I will still try. So sorry, coming back to Nandini, you wanted to trace what?
So the bony and cartilaginous roof lines. Actually, I think I was having a similar problem as Anika, which is why I was getting a little confused when you showed
Okay.
us how the tracing was done.
Okay. So your bony roof line starts from where the proximal perichondrium meets the ileum. Okay. So you're gonna draw, ideally you're supposed to draw a line, okay, which goes, kind of starts like this. And then you're gonna rotate the line towards the ileum till you get to a point that your line, sorry, uh, till you get to a point that your line touches the ileum here. So, so this would be your baseline. Okay. And the bony roof line, how do I erase this? Okay. Yeah. You're going to rotate it so that it touches, and this would be where your straight line is. So this is your bony roof line. I'm sorry, I can't draw any straighter lines freehand. And then your so this was the baseline. So the bony roof line starts from the lower and the innermost corner of your uh, lower limb of the ileum. And again, this line would start something like this. And then you are going to rotate the line towards the ileum. Okay. Till the point that it just touches the ileum. It should not be intersecting the ileum, or it should not be going through some point, but it just has to touch the ileum. Okay, so this is going to be your bony roof line. So now I'll erase the unwanted lines. 1 second. So I will erase this line, and I will erase this line. Okay, so the angle between these two lines, this will be your alpha angle. Okay. Is that what you were asking?
Yes, sir. And what
And
about
then about the cartilaginous line. So you would take the center point of your labrum and the turning point. So again, identifying the turning point is you have to start from the lower limb of the ileum, from the medial side, go proximal and lateral. Okay, so from distal medial you go to proximal and lateral, and the point where your concavity turns to convexity That is your turning point. Okay. So the turning point generally has a small acoustic shadow here, and just lateral to the acoustic shadow is where you draw that dot. So you're going to join this point and that point. So this would be your beta angle.
Yeah, thank you, sir. Yeah.
And Sanika, what were you asking?
How to exactly identify the turning point on the scans?
Okay. So here again, we'll start tracing from the medial side, lower medial to proximal lateral. And we are going to go from concavity to convexity. So the junction where the concavity is turning into convexity would be your turning point. Okay. So this section here is concave, 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 concave. And now this has started to turn convex. Do you agree? So this point, that is your turning point.
Okay. And these, matlab the scan has to be in the standard plane for us to draw this.
No. So again, so this is your first check. You're still in checklist one. Okay. So in checklist one, you're going to see the chondro-osseous border, femoral head. This is the synovial fold, which is overlapped by this letter D. Synovial fold here. This is the capsule. This is the labrum, cartilaginous roof, and bony roof, starting all the way from here, going down all the way medially. And then you trace your turning point starting from distal medial to proximal lateral, and then you go to your turning point. So you're seeing all these points. So this image passes checklist one.
Yeah.
Then you go to checklist two, which would be lower limb of ileum. You can see the bright big blob here.
Yes.
So this is the lower limb of the ileum, and you're going to, you can see the lower limb of the ileum. You can see that it is in the standard plane, which is indicated by a straight horizontal ileum. And the third thing that you can see is the labrum. So now, because it has passed, this image has passed checklist one and checklist two, you can use this to classify the hip by the graph classification.
Okay.
Okay. That is all. Any other questions? Okay. So then we will start with the early treatment. So basically, once you have diagnosed that the hip is dysplastic, depending on whether it is centered or decentered, you would treat the hip in some method. So the principle of treatment would be first to reduce the hip if it is decentered, then to retain the hip in the socket till it is mature enough, and eventually going to the maturation phase, wherein you allow the hip to completely normalize in terms of the sonoanatomy. So reduction should be done for all decentered joints, and it can be done by the use of traction, which was done previously historically by the use of Galos traction, wherein you're keeping the hips flexed and then gradually abducting the hips to cause reduction of the hip joints. You could also use manipulation in the form of closed reduction and hip spica to put the hip back in place. Or we could use a reduction device such as a Pavlik harness or some other harness of the physician's choice. Now, once you have applied the treatment of your choice, you will see that the hip is reducing. Once it gets reduced, then you have to retain the hip back in the joint. So till the hip stabilizes inside, you have to maintain that reduction by the help of a retention device, which keeps the hips in 90 degrees of flexion, about 40 to 45 degrees of abduction, and a relative immobilization for about 4 weeks for the hip joint to mature. Then eventually, all the hips which have completed the reduction and retention phase enter the maturation phase, wherein you wait for the hip to become completely normal on sonography. So you would continue your retention device till the ultrasound becomes normal. And during this period, you want to avoid hip extension because you want to prevent a redislocation. So there are various splints which are available. So this is the Pavlik harness. In the center, you can see a Freka pillow, and on the right, you can see a Von Rosen splint. So different centers use different splints, but the principle that you can basically see is that all of these splints are maintaining the hip inflection and abduction. Okay, so instead of picking a splint, I will talk about the principles of Pavlik treatment. So this is called a Pavlik method rather than a Pavlik harness. So what Dr. Arnold Pavlik said was that the hip joint is an organ of motion, and hence any pathology in the hip joint must be treated by active motion. So he designed this harness which keeps the hips in flexion and the knees in flexion. So the position of flexion of the hips and the knees allows the hips to abduct just by the force of gravity. So here you are not trying to force abduction on the hips, but allowing the adduction tightness of the adductors to gently ease out by gravity. So the flexion and abduction causes this position of flexion abduction causes the hip joint to gradually reduce, and then the same device helps you to retain the hip joint. So the abduction is determined by the child himself, and you're not forcing any abduction on him. The hygiene, maintaining hygiene is easy. The application of the harness is very simple for parents and for caregivers, and the device is simple and inexpensive. So these are the 7 principles of the Pavlik method. Then there was this beautiful paper by Simon Kelly on consensus for the principles of Pavlik harness management of hip dysplasia. So what the paper tells us is that the treatment should ideally begin before the age of 6 months of age, and a clinical examination and ultrasound scan is mandatory prior to commencing application of a Pavlik harness. So the harness has to be applied by a trained professional, and it has to be checked at each visit to ensure that the harness is being correctly applied by the parents at home, and that the harness is also fitting, because if you keep the same harness for a long time, the child is going to outgrow the harness. So if the harness is becoming too small, then you have to change the harness to a bigger size. Then you also have to monitor for femoral nerve palsy, which is one of the most common complications that you can encounter. If the child develops a nerve palsy, you are supposed to discontinue the harness till you can see from clinical recovery. And once the child recovers, you could start the harness again, albeit with a little lesser flexion. Then the consensus guideline tells us that there is some role of weaning from full-time wear to nighttime use only. And weaning can be instituted only once the ultrasound scan shows a normal hip anatomy. And the treatment can be stopped when the ultrasound is normal, as evident by an alpha angle of more than 60 degrees, a femoral head coverage of more than 45%, or a normal X-ray, which would mean an ISDI class 1. And there is actually no maximum duration to the Pavlik harness treatment. So long as the child can tolerate the harness, you might choose to keep the harness for a little longer while. So if the patient...
So Bhushan, what do you mean by when the hip appears normal on USG? Means the angles are normal or the hip is reduced?
Yes, sir. So the hip, the hip should be reduced, and you should have an alpha angle of more than 60 degrees.
Only then you can start weaning.
Yes.
Yeah, but that would take a long time.
So usually, sir, generally within 6 to 8 weeks, you should get significant improvement in the anatomy. So even in a stable dysplasia, within 6 weeks, you would get some improvement. And even in graph 3s and graph 4 hips, you can get, within 6 to 8 weeks, you can get decent amount of improvement.
Okay.
So if you think at the
So
end,
first stage is reduction.
yes.
So it is a dislocated hip. The first stage is reduction.
Yes, sir.
After reduction, the retention. The
Yes.
retention for how long?
Retention usually is for about 4 weeks or so, till the
4
joint
weeks.
stabilizes inside the socket.
Then comes maturation.
Yes.
And after maturation comes weaning.
No, so weaning can be started. Yes, right.
Nice class. Okay. That's why I don't want to miss.
Okay.
I have a doubt. Can I ask it
Yes,
now or
yes,
do I wait?
yes.
The reduction, how is that checked?
So I'm just coming to that in the subsequent slides.
Okay. Sorry.
So a stable dysplastic hip, which would mean a graph 2A, graph 2B, and even a graph type 2C, you would want the treatment to start at least by the age of 6 weeks, if not before.
This is not that nice as the one that we got from here,
Sorry,
no?
Ankita, can you just mute? Then the harness should be worn for at least 23 hours throughout the day. You can allow the parents to take off the harness for hygiene purposes, for bathing, etc. Clinical follow-up should be for every 2 to 4 weeks to adjust the harness and to check for complications. And the ultrasound can be repeated every 4 to 6 weeks to document improvement. So the treatment will last till the ultrasound is normal or for a minimum of 8 weeks. Then when we talk about a dislocatable hip, which would be a graph D hip, the treatment should ideally begin before the age of 7 weeks. And again, the harness duration should be 23 hours a day. You would follow up this child slightly more frequently, 2 to 4 weeks, to adjust the harness and to check for complications. And the ultrasound should also be repeated every 2 to 4 weeks to ensure that there is ongoing improvement. Here again, the treatment should continue until the ultrasound is normal or for a minimum of 6 weeks. For a dislocated hip, whether it is reducible or irreducible, you would want to begin treatment immediately following diagnosis. So even if the child is coming to you at 2 to 3 weeks with a dislocated hip on ultrasound, you can start treatment earlier rather than waiting for 6 weeks. So there is a small caveat here that, for a Barlow positive hip, wherein the hip is, at rest it is reduced, but on pressure it is dislocating, you could still wait for 6 weeks. But for an Ortolani positive hip or a hip that is dislocated, you would want to start the treatment as early as possible. So in a
Barlow is dislocatable, the earlier slide.
Yes, sir.
Okay.
So if a hip is dislocated, your harness duration should be 24 hours a day. You would not allow the parents to take off the harness absolutely until the hip is reduced. So once the hip is reduced, then you can probably allow them, just breaks for bathing and hygiene purposes. And you have to scan these hips weekly for assessing reduction by clinical examination, but you are not supposed to use any stress maneuvers during the examination. And your ultrasound also will be repeated weekly until the hip joint is reduced. Once you achieve reduction of the hip joint, your follow-up can then span to 2 to 4 weeks of clinical follow-up and 2 to 4 weeks of ultrasound follow-up. If you do not achieve reduction by 3 to 4 weeks, then you have to abandon the harness treatment. And if within 3 to 4 weeks you have confirmed that the reduction has been achieved, then you will have to continue the harness until the hip is normal or for a minimum of 8 weeks. Then I will be talking about the outcomes of Pavlik harness treatment. In Pavlik's own paper, which was published way back in 1953, he has described 100% success in treatment of dysplastic hips, 84% success in the treatment of dislocated hips, and the most important part is that he had 0 avian rates. Okay, so I want to stress again that Pavlik harness is the only method which gives you the chance of giving the child a normal hip joint. Any other treatment method that we do, closed reduction, open reduction, femoral osteotomies, DEGA, these will never give you a perfectly normal hip joint. So that is why it is really important to pick these up early. And if you can treat them successfully in a Pavlik harness, you can give them a normal hip joint. So recently there was this systematic review which was published on the outcomes of Pavlik harness, which reported a slightly variable success rate between 46 to 97%. So I looked up this article, and the cohort which had 46% success rate, they had included patients between 6 to 24 months of age. So it's quite high an age to try Pavlik harness. So it's understandable that the success rate is going to be lower than what you would normally expect. And then there was this other article which talked about slightly lower success rate. So in their patients, they were not able to achieve reduction in graph 4 hips in about 65% of their patients. So basically, your outcomes of Pavlik harness treatment are going to be affected by the age at onset of treatment So you want to start the treatment as early as you can. Then graft type for like I said, for a dislocated hip, the success rate can be slightly lower as opposed to a dysplastic hip. And bilateral hips are have a slightly lesser success rate as compared to a unilateral hip dislocation. Again, even in their systematic review, they have identified a 0.7% AVN rate in those who have been treated successfully in a Pavlik harness, as opposed to 11.5% that eventually failed Pavlik harness treatment. Then coming to the last part about when to screen and who should we screen. So basically, our Pediatric Orthopedic Society has, in collaboration with 6 other organizations, developed these wonderful guidelines for hip dysplasia screening in India. So these guidelines are based on the presence of risk factors and presence of instability on clinical examination. So the risk factors include breech presentation, family history of hip dysplasia, improper swaddling practices, which I think is seen in 100% of our patients, and if there is a history of clinical instability at examination. So during examination, you would want to see the Ortolani and Barlow test if the child is less than 14 weeks of age. Between 14 weeks and 6 months, you want to see if there is limited hip abduction, Galeazzi positive, or any leg-length discrepancy. And to add to this, in a child who is older than 6 months, you would also see if the child is limping, if they are walking already. So if you have a positive Ortolani, positive Galeazzi, LLD, limited hip abduction, or a limp, then you would refer the patient right to a pediatric orthopedic surgeon. And or if the child is less than the age of 6 weeks and the child has any other risk factors which we previously mentioned, breech, family history of DDH, swaddling, in a younger child who is less than 14 weeks, you would want to get an ultrasound scan in them. If the child is between 14 weeks to 6 months, you can get an ultrasound or an X-ray based on what is available to you easily. If the child is more than 6 months, then you can get a pelvis X-ray. And depending on what you find, whether it is abnormal or normal, then you can decide on the treatment. So then there is this, ongoing debate of whether we should be doing selective or universal screening. And there was a publication from the American Academy of Orthopedic Surgery in 2015, and they have given some clinical practice guidelines for screening of hip dysplasia. So what they say is that there is moderate evidence which supports not performing universal ultrasound screening. And it also supports performing some imaging study below the age of 6 months if there is one or more risk factors of these 3, breech, family history, or clinical instability. So depending on the age, you would perform some or the other imaging study in a child less than 6 months. It also says that there is limited evidence to support performing an ultrasound scan before the age of 6 weeks with a positive instability test. And there is limited evidence to support using an AP pelvis radiograph instead of an ultrasound at the age of 4 months. But then there is this other, other end of the spectrum wherein there is literature enough which says that there is no reduction in the rates of late diagnosis of DDH despite 26 years of instituting a selective ultrasound screening program. And the proponents of the universal ultrasound screening suggest that clinical examination is not infallible. And there is this very nice publication in JPO, which is titled "Even Experts Can Be Fooled." So they have taken all senior pediatric orthopedic surgeons and asked them to, clinically examine patients who had dislocated or dysplastic hips, and a lot of them missed significant examination findings. So clinical examination cannot be solely relied upon to diagnose hip dysplasia, because a lot of hip dysplasia is silent, and it also depends a lot on the training of the examiner. So in the German-speaking part of our world, in Germany, Austria, etc., there is literature which says that there is a reduction in the number and the severity of surgery for DDH with universal screening, and they have also showed that it is cost-effective actually. So this study by Biderman from Germany, in their study, the protocol that they follow is the first ultrasound scan is done within the first few days of life. even if the child is graph 1 or graph 2 within the first few days, they would still repeat a clinical examination and an ultrasound at the age of 6 to 8 weeks. If a child is found to be 2A, then they would be treated with like a double diaper or a big cotton diaper. If any patient is found to be 2B or beyond, then they would be treated in a tubinger orthosis until they normalize on the sonography. And with this protocol, they have identified, excluding graph 2A, they have a treatment rate of only 1%, and only 10% patients of 28,000 needed a surgical intervention. So major open surgeries were needed in only 0.07 out of 1,000 live births, and there were 0 late detections of hip dysplasia. Again, there was this Cochrane review of screening programs of universal versus selective screening. This was given in way back in 2013, which said that there is insufficient evidence to give clear recommendations because neither strategies have improved clinical outcomes in terms of late diagnosis and surgery. However, there was one other systematic review which was published recently in 2022, and it said that there is a statistically significant decrease in the incidence of late diagnosis of DDH with universal ultrasound screening. So just to conclude, most of the world is still following clinical screening and using ultrasound when there is a risk factor. And universal screening still is under speculation, but I think that is where the world is moving towards now. And probably as we recognize, eventually the rest of the world will move towards universal screening. And that's my last slide. Better ultrasound today than limp tomorrow. This was Professor Graf's statement from his book. Thank you.
Excellent. Learned a lot of new things today. Be sure to upload this on the YouTube channel.
Yes, sir.
Any questions? So in presence of risk factor, the first ultrasound is at around 4 to 6 weeks, right?
Yes, sir.
Positive risk factor.
Yes, sir. So again, so the POSI guidelines tell us that you should, if there is a risk factor, then you should refer the child early. But then again, there is a caveat here. If the child is less than 6 weeks, and if you feel that the child may get lost to follow up, you can still screen them right away, rather than waiting for the point of 6 weeks.
Okay, so if there are no further questions, I think we shall call it a day.
Okay.